Good morning, students. I am Dr. Roy, and as we all know, that we have started discussing rhinitis and its various types. So today, our topic of discussion would be acute rhinitis. Acute rhinitis can be of three types. That is the viral rhinitis, the bacterial rhinitis, and then there is an irritative type of rhinitis. But before we proceed with the lecture, I would like to recall and reiterate the definition of rhinitis. I know and I presume that you all know what is rhinitis, but again, just to recall and make you remember the terms and definitions, I am reiterating this. Rhinitis, not in medical gibberish, just to make you understand, in as simple as possible. Rhinitis is inflammation of the inner lining of the nose, that is the mucous membrane. The difference between acute and chronic, I presume that you all know what is the difference between acute and a chronic condition. So, the viral rhinitis specifically, because we're discussing acute rhinitis today, so acute rhinitis specifically is any inflammation or infection that lasts for few days up to 4 weeks. And in contrast, the chronic rhinitis would be any inflammation or infection of the inner lining of the nose or the mucous membrane of the nose and paranasal sinuses lasting for more than consecutive 4 weeks. So this is the basic difference that of the between the acute and chronic conditions. Please bear it in mind. The duration is very important because it defines the acuteness or the chronicity of the condition. The first type of acute rhinitis is the viral rhinitis. And again, the viral rhinitis is divided into three types. That is the common cold. The other term or the medical term for this common cold is coryza. The second is the influenzal rhinitis, which is due to influenza. And lastly, there is a viral infection that is due to exanthemas. We'll be discussing it in detail later on, but right now we adhere to common cold. So common cold is a viral infection and it can be due to different or several viruses, amongst which there is adenoviruses or picoRNA virus. There are different subtypes of picoRNA viruses, as for example rhinovirus, Coxsackie virus, and then lastly there is enteric cytopathic human orphan virus. Any of these can lead to common cold or coryza. The incubation period usually lasts from 1 to 4 days and the illness can last up to 3 weeks. Please bear it in mind. Patient who usually show up in OPD and they want some medical treatment from you, please make it clear to them if they are suffering from common cold or coryza, the illness can last up to 3 weeks. There is no magical medicine that we have on us that can instantly make them feel healthy. It can last up to 3 weeks. Please bear it in mind. This is very important for you. Right, we discussed the clinical feature, how the patient presents in the OPD. Initially, he or she has a burning sensation at the back of his or her nose that is later on followed by a sense of nasal blockage, discharge, and sneezing. Nasal discharge is also known as rhinorrhea. So initially, the nasal discharge is watery and profuse, but later on it may become mucopurulent. It's not incumbent upon every patient to have such kind of discharge, but in some patients, yes, it can become mucopurulent, which is due to a secondary bacterial invasion. The secondary invaders, I hope you all know, are Streptococcus, Haemolyticus, Pneumococcus, Staphylococcus, etc. Another important thing that I would like to mention here is the intensity of the fever, because at the end of this lecture you'll be given a sort of a quiz or you can say an assignment which you people have to submit within 48 hours. So the important constituent of that is the intensity of fever. In viral rhinitis, the fever is low grade. It is not high grade. Please commit it to your memory. The patient feels chilly. This is also important. Okay, regarding the treatment, bed rest is very important in order to curtail or cut down the course of the disease. The patient is encouraged to have a lot of warm fluids. he or she is supposed to maintain a good level of hydration. Apart from this, just to make the comorbidity or the quality of life easier, you can prescribe anti-allergics and decongestants. And if the patient is having headache, fever, and myalgias, you can also add analgesics. Another important thing that I would like to mention here is that one is supposed to give non-aspirin containing analgesics. The reason being, if you give aspirin, it leads to increased shedding of virus. So there is no point in viral rhinitis of administering an antibacterial, which is a common practice amongst our country or amongst our colleagues. This should be condemned. If you're suspecting viral rhinitis, there is no point of giving an antibiotic, or specifically an antibacterial. But there comes a role of antibacterial whenever you suspect that there is a secondary infection. And secondary invaders were, as you all know, you can recall, Streptococcus, Pneumococcus, Staphylococcus, Haemophilus, Klebsiella, Moraxella, etc. So there is a long list. I hope you all remember this. So this is important, that there is no role of antibacterial in the treatment of viral rhinitis until and unless there is secondary infection by bacterial organisms. Usually the disease is self-limiting and it resolves. I have already mentioned it, that it takes up to 3 weeks. It usually resolves within 2 to 3 weeks, but occasionally it can get complicated. And if you recall the anatomy or the surrounding regions, I have already told you many a times that there is no point in cramming different complications or different sequelae of the diseases. The easiest thing that you can do is recall the anatomy. So if you are discussing nose, you can recall what are the surrounding structures. You have paranasal sinuses, you have throat region, and then you have ear. I presume that you all can recall the complications that can occur, but still I will revise it for you. Okay, let us presume that patient is now having rhinitis and there is a certain complication that can occur. So in the vicinity of nose, we have paranasal sinuses. The sinuses can also get involved and lead to sinusitis. Apart from this, you all know there is a nasopharyngeal end of eustachian tube and the other end opens into the middle ear. So infection can ascend from the nasopharyngeal end into the middle ear, and that can lead to otitis media. You all know this, but just to reiterate the fact. And then the other complications, presuming that the patient is having acute rhinosinusitis, if the patient is having post-nasal drip and that is infected, it can lead to tonsillopharyngitis. The other complications such as bronchitis and pneumonia or the lower respiratory tract infections are also explainable in the similar way. The next type of viral rhinitis is the influenzaal rhinitis. It is due to viruses, influenza virus, that is type A, B or C, and again the signs and symptoms are very similar to those of coryza or common cold. But important thing to mention here is that there are more chances of complications in influenzaal rhinitis due to bacterial invasion as compared to common cold. And lastly, we have the third type, that is rhinitis associated with exanthemas. Okay, there is a term, this medical gibberish, exanthemas. What is meant by this term exanthemas? In simplest possible term, it is a rash. So viral exanthem would be any rash or eruption of skin that is a symptom of a viral infection. Different viruses that can lead to exanthemas or exanthematous fevers are measles, rubella, chickenpox, which is also known as varicella, roseola, and then there is a fifth disease. It is not mentioned in your book, but I presume that you people are studying microbiology, you are well acquainted with this thing as well. The rhinitis that is associated with exanthemas are preceded by these infections, and the chances of complications are more frequent and severe. The secondary infections are more severe, and then they can lead to more complications, more chances of complications that we have already discussed. So please bear it in mind. The treatment would remain the same as we have already discussed. So this is, I guess, presume enough for viral rhinitis, and now we'll be discussing the bacterial rhinitis. Okay, then there are two types of bacterial rhinitis. We have a non-specific type and then a specific type. In non-specific infection, Again, it can be a primary or a secondary. Primary bacterial rhinitis is commonly seen in children. Please bear it in mind. And is usually a result of infection with either pneumococcus, streptococcus, or staphylococcus. And on examination of the nose, you appreciate a grayish white tenacious membrane in the nose. And if you try to remove this membrane, epistaxis ensues, bleeding from the nose ensues. This is the primary bacterial infection. So regarding the second type, that is the secondary bacterial rhinitis, it is due to invasion or infection with a bacteria which occurs in a patient who is having viral rhinitis. So it is a superimposed or supervening bacterial infection. Patient is already having an acute viral rhinitis, and then there is a secondary invasion or supervening infection by a bacteria that leads to a secondary bacterial rhinitis. Lastly, we have this specific bacterial rhinitis, that is the diphtheric rhinitis. It is now a very rare condition to encounter diphtheria or diphtheric patient nowadays, but still, as it is mentioned in our books, we'll be discussing it in detail as well. Again, this diphtheric rhinitis can be primary or it can be secondary. The secondary diphtheric rhinitis is due to faucial diphtheria, and on examination, please bear it in mind, this is very important. In diphtheria, you appreciate a grayish membrane that covers the inferior turbinate and the floor of the nose. It is very tenacious. If you try to remove it, the bleeding ensues. And there is associated excoriation of the anterior nares or upper lip. It may or may not be present, but please bear it in mind. It can be present. And the treatment of diphtheric rhinitis is, first and foremost thing, is you isolate the patient. You curtail or cut down the exposure of the patient to other people. And then you administer systemic penicillin and you give diphtheric antitoxin. And lastly, there is a third type which is not mentioned here, but I will discuss it. That is the irritative rhinitis. As you all can, I guess, recall, we've already discussed allergic rhinitis. So irritative rhinitis is more or less same in its nature. It is due to exposure to dust, smoke, or irritating gases, which are usually present on, you should say, vocational or your job. You're exposed to this irritating gases. These irritating gases, such as ammonia or acid fumes. It can also be iatrogenic, which means it can be induced by a doctor. For example, a patient presents with a foreign body, nasal foreign body, and if you try to remove it, you're supposed to do some intranasal manipulation. It leads to irritation, and patient immediately has a catarrhal reaction that is followed by sneezing, nasal discharge, and then a sense of nasal blockage. Its symptoms rapidly pass off as you remove the offending antigen, or it can persist for some days if the nasal epithelium is destroyed. The recovery is instant, or if the nasal epithelium is damaged or destroyed, it will depend upon the amount of damage and the infection that supervenes. So we're done with the acute rhinitis, and at the end of this lecture, I'll post or float an assignment which you people are supposed to submit within 48 hours, and then on the basis of that assignment, your attendance will be marked. If you have any queries, please feel free to contact on WhatsApp group. Thank you very much.